Okay, so I'm just gonna get started. Thanks so much, everybody, for joining us today. I know it's a crazy busy time right now, so I really appreciate you taking the time to participate in this learning session. Today we're talking about vaccines. I'm Sarah Metcalf. I'm a program manager in long-term care and the moderator for this session. Just a reminder that this session is going to be recorded and will be posted to the COVID-19 internet page for access later on. This is also where you can find the recordings and presentations from our previous sessions. First of all, I would like to acknowledge today that I am a visitor working on the traditional unceded territory of the Lekwungen-speaking people, known as the Saanich, Songhees, and Esquimalt peoples. Please take a moment and reflect on and acknowledge the land that you're joining us from today. Again, thanks for joining this learning series. Our first 5 sessions covered how to prepare for, contain, and respond to a COVID-19 outbreak, as well as what to do in the event of an influenza outbreak, and a review of the current visiting policies and guidelines. Today we will be talking about COVID-19 vaccines and giving you the chance to ask any questions that you might have. If you do have any questions, if you could please post them into our Slido link, which was included in the email and poster that was sent out. Otherwise, if you just go to www.sli.do, the event code is #COVIDVaccine. And you can post any questions that you would like to ask the panel in there. We would also really like to get your feedback after the session. So I'll be posting a link for a short survey in the chat box for you to complete. This was also in the email that was sent out about the session, so you can access it there after the session ends as well. All right, so today we have a panel of guests that are joining us. We've got a couple of our long-term care directors, Carmela Betza and Philip Friesen. We've also got one of our medical health officers, Dr. Mike Benusik, Jayon Jones, the manager at Ukolta Lodge, Hilary Reese, CNL at Aberdeen, and Jessica Walter, an OT at Gorge Road Hospital. Thanks so much to our panel for joining us today. I am now going to hand things over to our presenter, Marina, who is going to give us a brief overview of vaccines to start us off.
Good afternoon, everyone. Thank you for joining us today. So the presentation today is just meant to be a quick overview, hitting some of the key points just to give a sort of baseline information about COVID-19 vaccines in relation to long-term care. Sarah, before I get started, if you don't mind taking over admitting people to the waiting room, then I'll be able to share my screen and concentrate on that. So can I just get some thumbs up out there? Do you see PowerPoint that I'm sharing correctly? Yes? Okay, good, thank you. So this is a hot topic right now. COVID, our objectives today for this presentation are to understand the role of immunization for COVID-19 in long-term care and assisted living, knowing that this is a high priority area. I'll be able to give you a bit of a basic overview of mRNA vaccines. I'll be honest with you, I wish I paid a lot more attention in grade 12 biology. I'm sorry, Mr. Lockwood, but I'll do my best. I'll give you a brief introduction to the vaccine process and approval in Canada. And then we'll have a bit of a review of some resources that are available for your informed decision-making process when you make your choice whether to vaccinate or not. So long-term care is a high priority for a number of reasons. Our population is unique in that typically people that by the time they enter long-term care, they have lived at home for a significant length of time, and we're supporting people in their homes longer than we ever have before. So when they come to long-term care, they are generally more advanced in age, and they're also more advanced with the chronic conditions that they've been living with. So people with comorbidities in advanced age are at higher risk of not only contracting COVID-19, but are also at higher risk of a more severe version of the illness. What we're seeing statistically is a higher mortality rate, significantly for people aged 80 years and over. Of note, in BC, 80% of our registered deaths with COVID-19 have occurred in long-term care homes. And the experience that we're seeing across the country is that for people who test positive when living in long-term care homes, it's anywhere from a 20 to 30% mortality rate, or about 1 in 5 people in long-term care will pass away from complications of COVID-19. Another piece that is not unique just to long-term care or assisted living, but also to other congregate living spaces, is that congregate living poses a risk of increased transmission if COVID is able to enter the home or the facility and is undetected, just because there's so many areas of crossover and interaction that can increase the spread if it does get in. In terms of vaccinating progress in long-term care and island health, so we know that residents, long-term care staff, and essential visitors are the highest priority in the provincial rollout plan, which is currently rolling out as we speak. In long-term care specifically, for island health, vaccine clinics are actually starting on Monday, with a goal to have the long-term care and assisted living sites completed by January 27th. Those are the goals. We'll see how that pans out as the clinics evolve, but those are the timelines that we're working with. Recent data, and actually this is slightly outdated. I had an update just now that 49% of long-term care staff have been vaccinated already, and clinics continue for long-term care staff to have their appointments and hopefully increase that number even more. What we know now from the number of residents who have provided consent and have doctor's orders is that we're looking at a high uptake of vaccination among our resident population, with numbers about 85 to 90% depending on the long-term care home. So a little bit about the mRNA vaccine. So right now there are 2 vaccines that have been approved for use in Canada. There's the Moderna vaccine and the Pfizer vaccine. What we know right now is that in most cases, because it is a bit more transportable, it'll be the mRNA or the Moderna vaccine that will be used for most of the resident vaccinations happening on sites. So with SARS-CoV-2 or the COVID-19 virus, it has a unique identifier on the outside of the virus itself, and it's those spike proteins. And what those spike proteins do, that's actually how the virus enters our own healthy cells. Once inside our healthy cells, the code from the SARS-CoV-2 virus tells our cells to start making more virus, and that's how we get sick. And it takes our bodies a little bit of time to recognize this as a threat, be able to know how to respond to the threat. And that's why we see a delay in our body's ability to respond when we have wild virus or an infection of COVID-19. Where the mRNA vaccine comes in is that instead of having to get sick and build that immune response, the mRNA vaccines contain the genetic information that our bodies need in order to make spike protein. Spike protein itself is not harmful, it doesn't make us sick, but it is that unique identifying piece of the COVID virus that our bodies use to recognize it as a threat. So with the mRNA vaccine, the mRNA is coated in a fat or lipid so that it can enter our cells through that vaccination process. And then the RNA, the messenger RNA is released, and that's what's telling our cells how to make spike protein. So our cells use this recipe to start making spike protein so that our body can recognize that spike protein as a threat and build the antigens or the antibodies, in order to respond to that threat. The spikes themselves, like I said, are not harmful, and the important bit is that our body now knows how to recognize those spike proteins and how to respond to it. After a few days, that mRNA piece, it breaks down and is gone from our body. So it's important to note that the mRNA itself does not interact with our own DNA. The mRNA is actually in the cytoplasm of our cells versus where the DNA is housed in the nucleus of our cells. So it doesn't become part of our genetic structure, and it does break down within a few days. As the immune process unfolds, our body has made these spike proteins. It's built antibodies in order to neutralize the spike proteins so that it knows how to respond. Our memory T and B cells kick in, and they constantly are surveilling our body for any possible threat. So that should we be exposed to SARS-CoV-2, it will recognize that spike protein that has entered our body, be able to immediately respond with antibodies and prevent that spike protein or that SARS virus from entering our healthy cells and making us sick. There's still questions now about how long our immunity lasts, and whether booster doses will be required in order to maintain our immunity. But this is sort of where we're at now with our understanding of the mRNA vaccines and how they work. So in Canada has one of the most rigorous vaccine development and medication development processes in terms of how new drugs and vaccines are studied. It goes through a 3-phase clinical trial. So in the first phase, what they're really looking at is the drug itself and whether it's safe. And they'll start looking at safe dosage, but it's not quite fine line yet, and any possible side effects. And this is in a small group of people. When phase 2 comes around, again, they're looking at more drug safety. They're able to determine a bit more of the efficacy of the drug, and because it's gone out to a larger population of people, and they're further able to determine the best dosage of the vaccine. Phase 3 is the largest group of people involved. Between Pfizer and Moderna, there was a total of 70,000 people tested in their clinical trials combined. And with that, they're really being able to target that efficacy number, in which case both vaccines are showing efficacy rates in the mid-90s for being able to prevent COVID infection in people who have been vaccinated. One important thing to note with our Health Canada regulatory body, they do depend on laboratory studies as well to prove things along the way. They do look at manufacturing, ensuring that a high processing standard is reached, as well as that the product itself is meeting the high quality standards that we do have here in Canada. Once a vaccine is approved and safe for use, it's also continuously monitored, and that's phase 4, which is essentially where we're at right now. And it means that in phase 4, data is continuously obtained through reporting and learning more about the best usage for the vaccine and long-term benefits and risks as well. What we're finding now, we're living in a pandemic, but we're also living in a simultaneous infodemic. And so getting informed is an important part of any personal healthcare decision that you make, but the abundance of misinformation and the abundance of false information out there makes it really difficult for people to find what they're looking for to make their own informed medical decision. So vaccination is a personal informed decision that we all can make. Finding reliable information is key. So knowing your resources, which I'll share a few on our next slide here, is really important, especially I do find, and I'm sure a lot of you can agree, as healthcare providers, people often come to us with their questions, their concerns, and often looking to us as a resource. And so making sure we're consuming reliable information ourselves so that the information that we are sharing is as accurate as possible. The other challenge with this is that the entire world is looking at this right now. This is a global pandemic. The entire world has a single goal in mind, is to stop this pandemic and to be able to provide options for treatment and prevention. So information is coming out at a really fast rate. I don't know if there's ever been a time in history when there's been so much flow of money to support all this research and work, with everybody looking at the same goals in mind. So we're finding out information as we go. So this is a situation where making the best decisions with the information available at the time you're making the decision. That's what you have to look at. It might be that down the road, more information becomes available and then you'll make the next best decision. But working with the information that we have is an important piece of this process as we've been rolling through this pandemic since March. It's a moving forward process rather than a looking back process. Some resources that helped inform this presentation and ones that are recommended for ourselves as healthcare providers and living in Canada and in the province of BC. So the BC CDC has a COVID-19 site with a number of resources that break down frequently asked questions about the vaccine. You can find the links, if you don't go to the Health Canada ones, for detailed information about both Pfizer and Moderna vaccines. BC government also contains a COVID-19 vaccine specific site, which talks more about our BC rollout plan and understanding the province's strategy around that. The two links provided there for Pfizer and vaccine, and this PowerPoint will be made available after the presentation, are to the specifics of each vaccine to understand the ingredients and the clinical trials that they went through. So I will stop there because we have an excellent group of panelists who are ready and available to answer your questions. And I will stop my screen share here, Sarah, and hand it over to you.
All right, thanks so much, Marina. Yeah, so now it's basically open to any questions that you guys have. We do have some questions already in Slido, and our panelists come from different disciplines. So we've got some folks who can speak to more of the operational side of the vaccine rollout, some who are more experts on the medical side of the vaccine. And then we've also got a couple panelists who have actually had their first dose of the vaccine. So if you have questions about what that process was like, please post that in Slido and we'll make our way through the questions. So, dear panelists, our first question that is in Slido is, are other types of vaccines expected to be available? And if staff decline the mRNA vaccine, will they be able to receive a different one in the future? I don't know if Mike—
I can take a stab at that.
Yeah.
Sure, thanks. And it's an excellent question. Oh, hi everyone again. My name is Mike Benusik. I'm one of the medical health officers. So I'm a public health physician and family physician with Island Health. And I've been doing most of my work now has been involved in long-term care and healthcare worker and acute care COVID-19 related issues. So I've been working with this team pretty closely. It's an excellent question. There are other vaccines that are in the pipes to be developed. The next one that looks like will be likely to get, the next one that will be up for approval in Canada will be the AstraZeneca Oxford vaccine. However, it's actually quite similar to the Moderna and Pfizer vaccines in that it uses still just a chunk of nucleic acid and tricks the body into making just a bit of that spike protein, like Marina so eloquently said. I think your biology professor would be very happy. And so it's I would say it's basically the same as the Moderna and Pfizer. However, the early studies with it suggest that it is less effective. So, you know, we've been hearing for people who have 2 doses of Moderna and or Pfizer, it's about 94, 95% effective at decreasing the chances of having symptomatic disease. Whereas in the AstraZeneca Oxford one, the studies so far suggest maybe about 70%. And so a lot less with a very similar vaccine. There's ones that are in future development that look like, that are more traditional vaccines, like they take a part of protein. Instead of tricking your body into making that spike protein, they actually just put the spike protein into the vaccine for you to actually create antibodies against it, or having inactivated virus particles. The reason why those ones have not been approved yet is because it takes so much longer for the development of those, because you have to actually grow vaccine, you have to grow the virus up. And that's why, you know, for flu shots, why we ask if people have allergies to eggs, even though it's irrelevant now, because there's not enough allergen in the flu vaccine to create an issue if someone has an anaphylaxis to flu, of which I digress, is because they're made in chicken eggs. And so you have to have thousands and millions of chickens to actually create all your flu vaccines. And so that's the reason why it's taking so long for those types of vaccines. They probably will be available, but I don't have an anticipation of when they would be. I'm assuming that if someone was dead set against getting the Pfizer or Moderna vaccines now, that I certainly don't think that would exclude them from eligibility of future vaccines when they're available. However, I would certainly say, I'll say this, if I was being offered, if I was on the priority list for vaccines, I would be rolling up my sleeve right now for Moderna and Pfizer. Everything that I've read about it and heard from my colleagues is that, you know, it's got pretty amazing effectiveness with, you know, the typical side effects right afterwards. And, you know, the theoretical side effects and long-term effects that sometimes are talked about are really unlikely. And that's why it's actually been approved by Health Canada. Long-winded answer to say yes and yes to those two questions.
Great, thanks so much, Mike. I think the next question could be directed for Carmela or Philip. Do we have an idea of when precautions may be lifted if staff, residents, and essential visitors are vaccinated, or will precautions be lifted at all?
Well, you know, I think that Mike can respond to that as well, but I'll take a stab at it. Right now, what we know is that once our staff get vaccinated and all our residents, we have, that is going to take I think, Mike, it is going to be, because there's two shots, it would be 14 days after that before people would have their sort of immunity. So we're actually looking at several weeks out. I am not anticipating that Mike or the other medical health officers are going to give us an order right away to say, or that Bonnie Henry's going to give us an order right away to lift the masks and the protocols. It's going to take a while. I think it likely will be phased. Am I right about that, Mike?
Yeah, I think that's pretty safe to say, and I'm happy you mentioned Dr. Henry there, because I will have no say in that. It'll be, you know, a provincial decision that's made about when we can start actually refining those restrictions in long-term care. I mean, huge kudos to all of you for being so for living in those restrictions for so long. I know that it's not easy, but I applaud you all. And I think that it certainly is necessary for us to actually figure out what the implications are for transmission within long-term care. Because while we know that the vaccine is pretty effective, like very effective, 95% effective at decreasing the chances someone will have symptomatic disease afterwards, the jury's still out on if people can still be infected with COVID and transfer it to other people. However, they won't get sick themselves. So we definitely have to figure that out before we start removing restrictions within settings, especially in settings that are so vulnerable, like long-term care facilities and assisted living facilities.
It is that Swiss cheese model, and that's what they often talk about, is you're plugging all of those holes as you move along. I mean, I think the hope is eventually we'll be able to decrease some of those restrictions, but it's going to take a while to get us there. But let's be optimistic today, because the sun is out.
There we go. And this may be a key point too, that even if you are vaccinated at this point, the public health orders still apply, whether we're talking about the physical distancing, the or reducing essential travel or restricting it, that the public health orders that apply to everybody still apply whether or not you've been vaccinated or not.
Great, thanks guys. The next question is around new admissions to long-term care. So again, this might be Carmela or Philip. How will new admissions be vaccinated if they arrive after the vaccine clinic is already held?
Okay, I'll jump in on that one again. So right now, so right now we are working on vaccinating all AAPs. So all those folks waiting, who have been assessed and waiting for placement, either in acute care or in the community, they've been identified and they are getting vaccinated. So that's what's going to happen right now. Down the line, how that's going to happen, not sure, but right now everybody is getting, that is identified as AAP, is getting vaccinated. So that should be complete within the next week or so. That's what I know to be true at this moment in time.
Always changing. More of a medical question. This writer says, I have GBS. Should I have the vaccine? Worried about effects of the vaccine down the road.
Yeah, excellent question. I'll first start with a bit of a cop-out answer that, of course, if anyone has specific concerns about their own individual medical situation and if they should receive the COVID-19 vaccine or not, I mean, the best place to turn to is your primary care practitioner. And I think that in regards to people who are either immunosuppressed or have an autoimmune disorder, the concern with someone who's immunosuppressed, let's say if they're taking a high dose of steroids for a condition, is that they may not have as good of a response as to someone who's not on that medication. There's not really a concern that they'll have like bad side effects. However, people who are autoimmune, there's a theoretical concern who have an autoimmune condition is that it could cause a flare-up, like for instance, if someone had Crohn's. However, there were people included within the study who had autoimmune conditions, and there didn't appear to be any differences with people who received the vaccine and those who didn't. However, it's a very small number of people. So we can't really draw big conclusions to say that it's certainly that no one's going to have a flare of an autoimmune condition if they were to be vaccinated. And that applies really to any vaccine. In regards specifically to Guillain-Barré, that's the issue is, of course, with the vaccine provided in 1976 for a specific strain of swine flu, that there was an increased incidence seen of Guillain-Barré after that. That hasn't been seen in other vaccines. It always is still something we watch really carefully. It hasn't been seen with Pfizer or Moderna that people have had either new Guillain-Barré or flares of Guillain-Barré. I know that the Guillain-Barré Society, on their website, they have some information from the US National Institutes of Health saying that they recommend vaccination for people who may be at risk of getting COVID if they've had previous Guillain-Barré. But if you really want that individualized discussion, the best person to talk to is your primary care provider.
Excellent. This next question we've spoken about a little bit already. I feel like Jayon might want to take a stab at this one. How long does the mRNA stay in the body, and will it make a copy of itself? Will it change the codon of the body's normal DNA/RNA sequence?
Wow, that's a long question. There's actually 3 questions in one. As Marina explained, mRNA doesn't stay in the body for very long. It's actually a very unstable structure. So the body is very efficient at making little recipes when they need to make something quickly, like let's say a new skin layer. You need mRNA to make those proteins. So when you're talking about a virus like this, the mRNA is actually piggybacking on our own protein synthesis system at the cellular level. And as soon as it's finished making that protein, it's gone. So, and it's unidirectional, meaning it comes from the nucleus where the DNA for our own cellular production is present, and it opens up and it's read to make a messenger RNA that comes out into the cytoplasm of the cell. So when the vaccine comes in, the mRNA goes into the cytoplasm of our cell and cannot go into the nucleus. So it doesn't go back into the nucleus, it just comes out. So mRNA just stays in the cytoplasm, does its purpose, and then dissipates. So it can't go back into our DNA and integrate into it. I think that answers part 3 of that question. And it's impossible to make a copy of itself. It's just one section and one piece of a recipe, and then it dissipates.
Great, thanks so much. And I think we touched on this as well earlier. How long does the antibody from the vaccine, how long is it good for? How long does it last? I think we said that the jury is still kind of out on how long it'll be effective for. Is that right?
Yeah, so it appears that it's likely from what we've seen, not in human studies, because it hasn't been that long since when the first people actually received the vaccines, but looking at in animal studies as well as in vitro studies. So when you just have like a petri dish and you're checking out how antibodies bind to stuff, that, wow, was really scientifically sound. See, I need to go back to biology 12, is that it's anticipated that it will be a year, at least a year, I should say, of immunity after the COVID-19 vaccine, Moderna or Pfizer. I certainly hope that, I would love for it to be, kind of like the measles vaccine, where you're good for life after you get a couple doses, but we will have to see as more evidence comes in.
Fair enough. Are there any concerns for breastfeeding women and their baby receiving the vaccine?
I'm happy to touch on this unless someone else wants to. Sounds medical. So, with any vaccine, medication, therapy, there's always the disclaimer that's provided is like typically that,
Hello, Jayon speaking.
those who are breastfeeding or pregnant may wish to speak with their physician beforehand, and a caveat that these medications or therapy or treatments were not studied in pregnant women. And that's understandable on one hand, that in studies you wouldn't want to use pregnant women or breastfeeding women as the first group that's being studied, because if there are concerns, you wouldn't want to introduce those risks. But then on the other hand, it also leaves a huge gap in that we don't actually have evidence of effectiveness and risks and benefits specific to those who are pregnant or breastfeeding. I mean, this applies to so many vaccines, for example. And then the evidence that we end up obtaining is from after the vaccine has already been out and then administered in those particular populations. In regards to breastfeeding, I mean, it's really, in my mind, I would love to hear other people's thoughts on this, but I think I can't really think of what a concern would be, because the mRNA bit itself, if that bit of nucleic acid was to end up in breast milk, then it's just going to be easily digested. It's so delicate that we have to transport it in either like -20 or -80 conditions. If it's going to make it through the body and get into breast milk, it's going to be pretty quickly just torn apart by stomach acid. And I mean, there's always considerations of, well, would this vaccination, if there's side effects, could that interrupt milk production? There's no evidence to suggest that it would at this time. There's anecdotal evidence I've heard from people who are breastfeeding who've received it that it hasn't. So to me, I don't see right now really an argument to not get it, but I still think it's a very individual choice that someone has, of course, if they are pregnant or breastfeeding. And I would encourage, if anyone's in that situation or they know other people in that situation, to read the document from the Society of Obstetricians and Gynecologists of Canada, the SOGC, because they've have a pretty in-depth, lengthy statement about looking at the risks, the benefits, the evidence, and then of course the ultimately, which I completely agree with, that it should be the informed consent of the individual.
Great, thanks, Mike. How long does it take for the vaccine to kick in? Is there a percentage of effectiveness after the first dose and then the second dose? And how long does that take?
Do you want me to go for it?
Sure.
So it's a great question. I guess it really depends on how the calculations are done, because, well, that was just going to be a long-winded answer. Let me give you the short answer, is that it seems that there's pretty good protectivity protectedness after the first dose. It takes at least 12 days for really any immunity to start, I shouldn't say immunity, for any protectedness to start developing. And so certainly, like, and that goes back to the original point about after someone's been vaccinated, it doesn't change the practices that we are advocating it and would recommend, continue working and being in the community the same way you would without having the vaccine. It seems that after 12 days, that's when there's about, I think it was 60% of people would be protected against symptomatic disease. And there's been some recalculations to say that by the time that people are getting their second dose, they're probably within the 90% range of having some protection against symptomatic disease. However, no one knows how long that lasts for. And one of the big reasons for the booster is to try to really lengthen the duration of immunity. And that goes into, again, I think there might be another question about this, and if there isn't, I'm sure there will be, about why there might be a shift from what the monograph says about when the second dose should be provided to when BCCDC and the provinces is now put forth. So Moderna and Pfizer were 21 and 28 days, I think, respectively, after the first dose. But now the BCCDC is recommending from 35 to 42 days after the first dose. And the reason for that is when we look back at the evidence and all the people that were enrolled in the studies, there was a spectrum of when they were actually provided that second dose, between, I think, 19 days and like 42 days or 45 days even, between after the first dose. And there wasn't any evidence to suggest that people who were provided that dose later in that interval had any decreased effectiveness against symptomatic disease. And so the benefit of that is, while we want to get as many people vaccinated with that first dose as we can, we certainly want to make sure that we're following the protocol and ensuring everyone gets their second dose on a time frame. But by pushing it out to the edge of that interval, that'll allow us to have an extra week where we can really be providing that first dose of vaccine to everyone, because we are incredibly efficient on the island. By whenever we get vaccine, we use it, which is good because there's nothing wasted and there's no delays, but it's also we want to make sure that we are providing it to everyone that we need to.
Great. The next question is, will I have to wear a mask all the time at work if I don't get the vaccine? Like, and then in brackets, like when you don't get the flu shot, but year round.
But I know to be true at this moment in time is that is the case. What I understand right now is that for those staff who cannot get vaccinated or are choosing not to get vaccinated, you will be required to wear a mask at work. Whether or not that will be just for the time of COVID or going beyond that, I don't know the answer to that at this moment.
Okay, thank you.
Mike, did you have any thoughts on that or comments about that? Anything you've heard?
I think it's way too early to really give an answer about what's going to happen. But as for now, it's still universal masking for everyone.
And one of the difference between the flu and COVID is that the flu has a season. I've heard Dr. Fife refer to this. So we have a flu season, whereas with COVID, we don't have a COVID season. It appears to be a year round at this point. So that would be another reason why mask wearing would be year round or all the time, because there's no COVID season per se.
Right. Okay. Immunocompromised resident getting IVIG, should he get the vaccine? previously advised by immunologists not to get pneumovax because won't mount a response. Thoughts on that?
Yeah, that is an excellent question. That would be something where I would need to, actually look into that in depth, speak to the immunologist, his treated immunologist about that, because it's so incredibly specific. Because this goes outside someone just being immunosuppressed or someone having an autoimmune condition. This is someone who's also receiving who's receiving antibodies that may just make the vaccine irrelevant. But it could be based. There could be the chance of provided it at a specific time frame between the doses of IVIG, but I would have to know all the details about that. So I would be more than happy to be looped into that person and try to get an answer to that. But it'd have to be offline because I don't know right now.
Perfect, thanks, Mike. The next comment is, there seems to be confusion regarding essential visitors and social visitors, and families are expecting to be on the list as essential. I can speak to this a little bit, and then Marina, I don't know if you want to comment, but basically we're working on updating our essential visitor and social designated visitor guidelines and getting it to mash up with new ministry information and interpretation of the visiting guidelines that we got. So that'll be available to sites and the public shortly. Marina's actually the one working on all of that, so I don't know if you want to comment.
Well, now I'm in the hot seat. So I think the question is going back to that definition of an essential visitor versus a social visitor. And what we know to be true is that all family members or friends feel that they are essential. Unfortunately, there is a bit of a delineation right now between what is essential, which means that the need of that resident is not being met in the absence of that visitor, versus a social visit is more for socialization purposes versus meeting an essential need. So for people on your designated essential visitors, sites were asked, I think about 2 weeks ago, if I'm not wrong, to send in their lists of people who they had designated as essential visitors. And those people were contacted by the call center in order to be able to make an appointment to receive their vaccine. Moving forward, Sarah, I think there's going to be an updated process for how people who are deemed as essential visitors can make that connection and get their vaccines. For the moment, at this time, people who are social visitors are not part of that high priority group as we know it to be true today.
Thank you. Long-term care staff second dose, what to do if there's no appointment and they're approaching 42 days from their first dose? Carmela or Philip, I don't know if you've heard anything about second doses rolling out for folks who were early on in the first dose rollout.
No, I haven't. For staff?
For staff, if they haven't been contacted to book their second appointment yet and they're coming up on their 42 days.
What I know right now is we're getting the first doses out right now. I know that the staffing offices or the call center is scheduling as we move through. They will be hearing.
Okay, so they'll be receiving a call for their second dose. Yep. Perfect. So
I've got to jump off. I'm sorry, I've got another meeting. So thank you. Bye, everyone.
Thank you, Carmela.
Thanks, Mike. Thanks, Marina.
So we are at time. We do have a couple more questions. I'm hoping we can touch on those. If anybody needs to jump off, feel free. I know it's a busy time right now, but if you are able to stay on for just a couple more minutes, we've got like 3 more questions left. So the next question is, according to the BC CDC, mRNA vaccines have been studied for decades, but not used widely in human vaccines. From this data available, are there long-term effects. Jayon, I don't know if you want to speak to that.
For long-term effects, I don't think there is. I think the reason they haven't had a chance to use it for vaccinations is because there was no money, no funds. So this is a synthetically produced vaccine. There are no organic vehicles to produce the vaccine, and it's just a short nucleic acid strand that's enveloped in a lipid particle. So it's not something that would actually cause long-term effect, because it doesn't stay in a body for very long either. And the outcome of receiving the vaccine versus the outcome of getting the disease itself far outweigh, I guess, the devastating effect of getting the disease. Like, I'd rather get the vaccine than the disease. Some of the information I researched was the long haulers who are still feeling the effects of COVID-19 because our immune system is so efficient and can be so can be used against us, I guess, because if we have COVID-19, we have a systemic infection that attacks our brain and our organs. Our body still thinks it might still have it. So that's why they're having these long ill effects. I don't know if Mike, if you want to comment on that, but it's really important to understand that even though we've never used it in human vaccines, it has been used in animal vaccines. And it's not new technology, it's old, it's been studied for 30 years at least. It's just we didn't have the funding to go ahead with a vaccination program with it. They were looking at cancer treatments for different kinds of cancers with that technology. So it's cutting edge, it's new, it's innovative, and our country wouldn't approve something that wasn't safe because of the stringent requirements that need to be passed.
Yeah, I agree, Jayon. That's a great answer. And I think that, you know, cutting edge, new and innovative is exciting, but then also leaves that bit of, well, what about like the tried, tested and true methods that were used before? And so I think it's very understandable for there to be kind of like this little bit of apprehension, think about like, well, what exactly is going to happen? And I mean, I agree with that. I really trust the review process. Nothing was like, no shortcuts were taken with the approval process. Things were fast tracked. Like maybe before, when, you know, someone receives a huge stack of studies on their desk, they have maybe a couple months to review it, but now Health Canada only had like a couple weeks to review it. So things were done quickly, but they weren't done in a way that was not up to the standard level. And I do think that, you know, the majority of people, especially those who are in like the age group of people who are working, they do recover from COVID, and they have no complications. However, you know, there seems to be a significant portion of people who have some effects that last for at least 6 months. And so I do think in terms of like long-term risks that the what seems to be real long-term risks from COVID, to me, outweigh any potential theoretical long-term risks regarding the vaccine.
Great. Yeah, so just last couple questions. I'm just going to move through them a little quickly because I think we've sort of touched on them a little bit. If staff do not choose to have a COVID vaccine and there is an outbreak, will they be permitted to work or will they be sent home? Again, I think this is still a bit up in the air right now. Everything is status quo. Nothing has changed as far as precautions or coming to work from what I've been hearing. Things can change. This is how the information is being presented at this moment in time, but in future we could get new information. So yeah, it sounds like there haven't been any major updates as far as people who are vaccinated versus not vaccinated. Everything is status quo. Is that correct, Mike? Anything to add?
No, I agree.
Perfect. And lastly, will vaccinated long-term care residents not be required to quarantine if they are newly admitted from the community or are returned from a hospital stay? again, I feel like this is kind of the same answer. Status quo for the time being. Could change, but for right now, still the 14 days of isolation on admission or return from hospital. Can I get a thumbs up? Cool. All right, and so that has gotten us through our questions here. I am aware that we had a couple panelists who have actually had the vaccine. I don't know if you wanted to make a quick comment about what that process was like, or what the experience was like, if you'd like to make a comment.
Test to it. Today has been a full 7 days. I actually received the vaccine just after 3 o'clock, so it'll be a full week. All I felt was a little pinch and then a couple days of mild arm soreness. Now, I know when I received the flu vaccine, I couldn't even lift my arm up. So it was a completely different experience. I promise I'm not growing an extra appendage. I was having a little touch base with my residents. They were very curious about the vaccine themselves because they're receiving it on Tuesday. So I couldn't believe the crowd out front when they came out to meet with me to ask very, very good questions about the vaccine. And when I joked around that I don't have a third appendage growing, someone said, well, maybe you have eyes in the back of your head. So I had to turn and check to see if I had eyes. So they're very encouraged and very excited about receiving the vaccine so they can go back to normalcy to some degree. So I highly recommend and endorse the vaccine.
Great, thanks, Jayon.
Yeah, and just to echo that sentiment, I also had a very positive experience receiving the first round of the Pfizer vaccine back on December 27th. And something that really stood out to me is the public health nurse who administered my vaccine really took the time to provide some very thorough and accessible education, just with regard to lots of kind of the questions that came up today around how does the vaccine work and side effects that I might experience post-vaccine and kind of the reasons why and how my immune system would be responding. So I found that was a really positive piece of the whole experience for me.
Great, thank you, Jess. Any other final comments from our panel? All right. Well, with that, I'll let everybody return to their afternoons. Happy Friday. Hope you get to enjoy a nice sunny weekend. And thanks everyone for joining us today. All right, take care.
Thanks everyone, bye.
Thank you.